I've been entrusted with presenting the data. The data is not mine, but that's the task before me. There is a lot of information, and I think it's best if we present it in small sections and then we open it up to questions, because if we leave it to the end of the presentation, I think you probably will have forgotten what the issues were that you're interested in clarification. Now, as I say, the data is not mine. It's come from a number of different sources, and we'll acknowledge those at the end of the presentation, but I would at the outset like to acknowledge the outstanding work that Morella Matthews has done in getting all this data together, collating it and preparing the presentation so that it was almost a fait accompli when I came to look at the results. So in this presentation we'll talk about the incidence and survival, the lung cancer population and presentation, and the care patterns and variations across Victoria, including diagnosis, staging and treatment planning, treatment, mostly surgery, but a little bit about chemotherapy and radiotherapy, and a little bit about supportive care and palliative care. So the optimal care pathway for lung cancer you've heard mentioned already. This is now complete in its revised form, and many in the Summit audience have participated in this work, so you'll be familiar with it. Today we're going to concentrate on these highlighted elements, which are diagnosis and staging, treatment and end-of-life care, and the components of the pathway. Now, the sources of data that we have to inform us today come predominantly from the Victorian Cancer Registry and the Victorian Admitted Episode Dataset, the VAED. We also have the Victorian Patterns of Care study, which contains information not available from these other datasets. It is, unfortunately, relates to patients treated in 6 months of 2003, so rather old, but there is still some important and informative data there. We also have the Victorian Radiotherapy Minimum Data Set and the Victorian Lung Cancer Registry, and some performance indicator audits to provide the information. So the linked data between the Victorian Cancer Registry, which is linked with the hospital activity data, enables us to track each patient across Victorian public and private health services, allows identification of admitted lung cancer cases, so admitted cases, not outpatients, and allows mapping of the patient's pathway. The radiotherapy data, which is largely outpatient data, so not covered by the VAED data, comes from a different data set, but we do have some interesting information on that. So the limitations of the data set are that the Hume region, which as people know centres around Albury-Wodonga, is not reported to the VAED or the VCR, was not available for analysis. Staging is not currently available for lung cancer in these data sets, although it is available in the patterns of care data. And some of the observed differences that we are going to show you could be due to the lung cancer patient's disease or characteristics such as stage of the disease. So the good news is, at least for males, that the incidence and the mortality of the disease has been declining steadily in the last 20-odd years, 30-odd years I should say. There's still a little bit of concern that there's an increase in mortality and incidence in females, but they're coming closer together, so this is equality in lung cancer. The relative 5-year survival is improved over time from about 8% in 1986 through to 14%, and I think the latest data show that it's now up to 15%, and that's a statistically significant increase, and I think that is, although it's generally poor compared with other cancers, it is in line with best reported data from overseas. As people are aware, age is an adverse prognostic factor. The older you are, the worse your survival. This just refers to the integrated cancer services. I don't think they need any introduction because we all work within those one of those ICSs, and they've been with us now for a long time, but they provide an opportunity to compare the outcomes and processes in different socio-economic groups and geographic regions. So using the ICS, we can look at the 5-year incidence numbers, and you can see that the raw numbers show quite dramatic differences related to the survival to the populations. But if we look at the age standardised incidence between 2008 and 2012, we can see that in Gippsland and Loddon Mallee, so Loddon Mallee's around the Bendigo up to Mildura region, there's a higher incidence of disease, and the northeast metro, there's a slightly lower incidence, and otherwise the incidence is fairly comparable among the other ICSs. This is the relative 5-year survival by ICS of residents, and it shows that there is no significant difference with overlapping confidence intervals, but you can see that some sites seem to have a non-significantly lower survival, such as Grampians. Across the metropolitan sites, these survivals are fairly comparable. This is an important slide, however. It does show that if you live in the regional ICS as opposed to metropolitan, then your survival is significantly worse if you have lung cancer. And this is highly statistically significant. All right, the lung cancer population of presentation. So as noted, there is a change from it being a predominantly male disease. It's getting less male dominated. From 2003, 63% down to 60% in the most recent data. Slight drop in age. The problem of no tissue diagnosis is still with us. So patients are still being entered into the Victorian Cancer Registry on the basis of death certificate alone and no histology. And that doesn't seem to have changed much from 10% in 2003 to 13% in the most recent cancer registry data. A small cell is only a small proportion of the total and appears to have dropped from 13% to 11%, and the dominant histologic subtype is still adenocarcinoma, which appears to be increasing in incidence, squamous cell carcinoma, and probably due to more precision of pathologic diagnosis, large cell has gone from 13% to 5%. Going back to the patterns of care data for smoking history, 8% of patients in that study were never smokers. The majority, 57%, were past smokers. And at the time of diagnosis, only 35%. So this is fairly common experience that most of our patients are ex-smokers. Most of the non-smokers who develop this disease are female, and that's a statistically significant difference. 14% of female lung cancers are non-smokers versus 3% of males. Previous smokers ceased a median of 12 years earlier, so it's quite a wide range of, if you like, quit period. Tobacco exposure in smokers, median of 50 pack years, and interestingly, females only had to have 37 pack years versus males 52 pack years. Again, highly significant difference, suggesting that females are more susceptible to the carcinogenic effects of tobacco smoke. So this is the gender distribution by X, and there's no significant difference there. This is an interesting slide in that it looks at lung cancer by place of birth. So you can see that the percentage born in Australia, it's around 70 to 80% in patients in the regional X versus 40 to 60% in the metropolitan X, which is not surprising. However, in the Western and Central mix, it's almost it's under 50% of patients that were born in Australia. We think this may be an issue in relation to familiarity with the nature of the disease, the need to seek earlier diagnosis, and maybe language difficulties inhibiting people from seeking medical care. And we do know, at least from some Western Sydney data, that people who never receive treatment are more likely to have been born overseas. So this is interesting data in that regard. The stage distribution, we don't have that, as I've mentioned, but in the patterns of care study, 18% had stage 1 disease, 5% stage 2, about a quarter were stage 3, and the majority of patients are still patients with metastatic disease, 52% at the time of diagnosis. We can obtain from the cancer registry data some information about metastases recorded, and this may be a surrogate, if you like, for stage 4 disease. It is a little bit below the 52% figure I showed you for the patterns of care study, and it may be due to underreporting, but we can see that between 35 and 40% of patients are coded as having distant metastases within 4 weeks of diagnosis. There are some differences there, with maybe more patients with metastatic disease in Gippsland and Grampians, and fewer patients in, say, Smicks and Hume. So tissue diagnosis. This relates the likelihood of a tissue diagnosis according to age group. And as you can see, there's an increasing trend as people get older not to have the diagnosis established by tissue, and this is statistically significant. As I mentioned previously, there hasn't been a great deal of change over a period of time between 2008 and 2012. Maybe a slight improvement. The test of trend, however, is not statistically significant. So we still have the problem of 10 to 15% of patients have no histology or cytologic confirmation that they have lung cancer. This just shows the age, the adjusted odds of having a tissue diagnosis by region of residence. Gippsland is probably the outlier here. This was adjusted for age, gender and country of birth, but not adjusted for stage. Timeliness of diagnosis and treatment, and this is an issue that has been of concern to us, and thanks to the Victorian Lung Cancer Registry for this data. So this first slide looks at the number of patients where the time from referral date to the diagnosis is less than 28 days, and this is a funnel plot. And what you can see is that 66% of patients overall are falling within the 28-day time of referral to diagnosis. But some sites are doing particularly well, and we can see up here this site has got 94% of patients meeting that criterion. Another site's not doing quite as well, with only 55% here meeting that criterion. So there is a wide range of variation, and it doesn't necessarily correspond with how many patients or cases are seen within that particular service. This second slide from the cancer registry shows the number of patients where the time from diagnosis to first treatment date is less than 14 days. And again, we see that 56% of patients met this criterion, but there's again a very wide range of variation. One side it was only 31%, admittedly smallish numbers, but other sites are doing particularly well with 70%. Seems that maybe sites with smaller numbers take a longer time to get to from diagnosis to treatment, but that's not always true, as you can see. So this is a small medical record audit done in SMICS, looking at the interval target times audit, doing an interval target times audit. So the results of this 98 patient audit: diagnosis within 28 days, 71%. Initiation of treatment within 14 days was 48%. So these are some of the issues identified in the SMICS audit to getting timely care: no priority triage, delay in receiving information and patients going to the wrong location, EGFR testing, bronchoscopy, VATS and EBUS availability, although interestingly PET's not mentioned there. All the issues that we're so familiar with in practice: lack of information in the referral, absent radiology access, variation in staging procedures, identifying a responsible clinician, multiple referrals, pathology turnaround, no palliative care, inappropriate referrals sent to the wrong specialist, delay in EGFR testing, preconception rate curability, waiting on the next MDT, limited chemotherapy day unit or radiotherapy capacity, and palliative delays. So all those issues that are familiar to us in clinical practice. Treatment planning, the multidisciplinary team model of care. So there are a lot of multidisciplinary meetings which are sometimes lung specific, sometimes involve upper GI, but all the ICS have active multidisciplinary meetings on a regular basis, and you can see, I think that summarises all the ones that are in the regional and metropolitan areas. So for newly diagnosed patients, these are not patients who have recurred or being discussed a second time. The multidisciplinary meeting, the average figure is 62%, with quite a lot of variation, as you can see, between the ICS. Some patients, the trend though has been an increase in likelihood of being discussed at an MDM over time in all the ICS. The patterns of care study, the discussion was only at MDM was only occurred in 29%, so there has been a significant improvement up to the average figure of 62%, so that's encouraging. And going back to that patterns of care study, the cases who are discussed at an MDM were much more likely to be younger. They were much more likely to be treated with curative intent. They had better performance status, early stage disease, and they are more likely to receive treatment. And importantly, there did appear to be an association between better survival and having your case discussed at an MDM. Now, in the patterns of care study, some patients may have died too quickly for an MDM discussion to be held, so we did a landmark analysis which excluded patients who died within 2 months of diagnosis, and we still found that there was an improved survival, which was statistically significant, and a multivariate analysis, including all the significant variables, still indicated that multidisciplinary meeting discussion was an independent prognostic factor for survival, both for all lung cancer and for non-small cell lung cancer. Staging. This is from the Lung Cancer Registry. So this looks at the number of patients with clearly documented PET diagnosis who are undergoing curative resection, and we can see that there is again significant variation, with some sites only having around 60% of patients getting a PET scan, and other sites achieving figures in the 90s. Interestingly enough, even in 2003, before curative surgery or radiotherapy, when PET scanning wasn't so widely available, there was still a very high proportion of patients having PET scan before surgery, around the 80% mark. This looks at the number of patients with clearly documented TNM, clinical TNM staging at diagnosis, and some sites performing very well, with over 90% of patients having the TNM staging documented, other sites not performing anywhere near as well, with as few as 7%. 49% of patients overall had their clinical TNM staging documented at diagnosis, so probably room for improvement there. This slide looks at the staging, the MDM documentation. So the average figure is 73%. I think we can see a trend to improvement in the documentation of MDM in the over time, but some variation between metropolitan and regional sites. All right, we'll look at the surgical data that we have. So major lung surgery from the Victorian admitted episode data set refers to pneumonectomy, lobectomy, partial resection and other excision procedures. So this shows the major lung cancer surgery by X of residence, and we can see that there are variations, although not statistically significant, at 0.056. Lower percentage of patients in Grampians and higher rates in the metropolitan centres, or metropolitan X, as you might expect. So the odds of having major surgery by region of residence, so if you're in NEMICS or SMICS, you have a greater likelihood of having major surgery. The other sites, the confidence intervals overlap the line of equivalence, and so there's no comment. These data are adjusted for age, gender and country of birth, but not adjusted for stage. This shows the ratio of lobectomy to pneumonectomy by region of residence, not the region of where you had your treatment. And pleasingly, I think the pneumonectomy rate is consistently around 10% across the regions of residence. This is the ratio of lobectomy to pneumonectomy according to X of treatment. So Gippsland and Hume, of course, don't do major thoracic surgery, and we see that again the pneumonectomy rate is around 10%. The fact that there are no pneumonectomies in Grampians suggests that the patients may be referred to one of the other X. And this slide indicates the X of treatment by X of residence. So this is the X of treatment, and you can see that, and this is the X of residence. So at first admission, So a lot of patients you'll see are referred from their residence to one of the major metropolitans to actually have their treatment. So vast bulk of major surgery is performed in the metropolitans and in Barwon. Nevertheless, there is quite a variation in the major surgery by health service. So this is again from the Victorian admitted episode database, and this is the number of procedures performed annually, and we see even in regional and metropolitan, public and private centres, there are still some centres that are performing major surgery and doing less than 20 procedures a year. Quite a few in the private sector. Importantly though, the differences that we noticed before in terms of survival, regional versus metro, where the metropolitan patients seem to have better survival, this does not appear to be due to surgery. So this is X of residence, not X of treatment, because there's obviously not a lot of surgery goes on in the regional X, and you can see that there is no difference in the surgical outcomes depending on where you live. This shows the 30-day mortality following major lung cancer surgery, and it's 5% or under in all those X. We have a little bit of data on chemotherapy. Chemotherapy within 90 days of major lung surgery, so this is 90 days after major lung surgery, is taken as a surrogate for adjuvant chemotherapy, and we don't know if it was adjuvant chemotherapy, but that's what we're presuming it to be. And we can see that there are quite significant differences between some of the X, with very low rates in the Grampians and surprisingly in my own WICMIX, with 15% having chemotherapy within 90 days, compared with the NEMICS, Hume and Gippsland, where it's up to 30%, so almost double the rate of having chemotherapy after surgery, and a highly significant difference by region of residence, not region of treatment. And this just shows a similar slide for patients who've had lobectomy or pneumonectomy as a subset of the total patients having major surgery. And again, WICMIX and Grampians do seem to have lower rates, and Gippsland, NEMICS and Lotomelli higher rates. And this just looks at the adjusted rates by region of residence and adjusted for age, gender and country, but the vital piece of information that's missing is stage. And WICMIX is on the low side and NEMICS is on the high side, but the others all cross the line of equivalence. Getting towards the end now, radiotherapy utilisation. So it's been estimated by Michael Barton's group, CCOR in Sydney, that 77% of all patients with lung cancer should have radiotherapy at some time during their treatment. And what we see here is that the figures in Victoria show only 48%, so well below the figure that's based on the best evidence. We see some variation going up to 51% in the best utilisation closest to the CCOR prediction, which is again my own mix, and down to 34% in Grampian. So again, a lot of variation across the state, but overall suboptimal. Curative versus palliative, I'm not sure what we can make from this, but the predominant treatment is, of course, palliative radiotherapy. Most ICS, it's around 25 to 30%. In Barwon, it seems to be a little bit lower, patients having curative treatment. Hard to know why that would be. So supportive care and palliative care, and these are our last slides. So this is from the Cancer Registry. This is the number of patients with documented screening for supportive care, and a disappointing figure of 27%. I think screening is the aspirational goal of in Victoria is that 50% at least should have screening. And we see very wide range from very low levels to quite good levels above the 50% to which the department wants us to achieve. This shows the supportive care needs screening across the ICS, and again a very wide variation without me having to dissect down by ICS. Palliative care access, this is from the Cancer Registry. Again, the number of patients with stage 4 disease referred to palliative care where the time between date of diagnosis and date of referral is less than or equal to 56 days. And you can see that the figure is 82% across all the sites covered by the Cancer Registry. So that's quite a good figure, but a little bit of variation evident there from 74 through to 91%. So conclusions are that lung cancer survival is trending upwards. There's significant variation in 5-year survival, regional versus metro, as place of residence, not place of treatment. Some difference in the likelihood of receiving a tissue diagnosis across the ICS. Some data suggests that timeliness of diagnosis and treatment is an issue, and there are still low volumes of major lung surgery going on in a number of health services. Lung MDM case discussions are relatively low at 63% for the state. Variation in rates of adjuvant chemotherapy across the ICS. Overall underutilisation of radiation therapy, and low and variable uptake of formalised supportive care screening. So I just acknowledge all the members of the working party and the project team, and big thanks to the people who provided data, Rob Sterling from the Cancer Registry, Department of Health, Catherine Whitfield and Vicky Thursfield and Georgina Marr at the Victorian Cancer Registry, and to our statisticians who provided the statistical fine-tuning of the data.